I feel sorry about the little delay because of technical problem. Before we start, I would like to mention that I have no conflicts of interest or relevant disclosure to mention over here. I have used certain slides from the original talk of the ACR 2024 guidelines for the systemic lupus erythematosus. And here are my references for today's talk. The outline of my talk includes a brief background followed by an overview of the ACR 2024 guidelines for the lupus nephritis. And at the end, we will review the application of new knowledge in the clinical setting. A little bit about background. Ladies and gentlemen, as you know that the SLE is a heterogeneous autoimmune disease with variable course and clinical prognosis. The signs and symptoms can be subtle or robust that affects a single organ system or several and change over time, making it a difficult disease to diagnose. This clinical heterogeneity likely stems from the complex immune dysregulation that results in the SLE disease pathogenesis. SLE may be more prevalent among most ethnic groups in the low and middle income countries, but these countries are still underrepresented in the epidemiological data on SLE. The prevalence and incidence of SLE varied from 3.2 to 159 per 100,000 and 0.3 to 8.7 per 100,000 persons respectively. A paradigm shift has been observed in the treatment of lupus nephritis. More recently, there are new developments in the field of lupus nephritis, and that has led to an impetus for the development of new guidelines for lupus nephritis. A second biologic agent, anifrolumab, has been approved for the treatment of SLE, while the field of lupus nephritis has witnessed major breakthroughs in the form of belimumab and voclosporin, a novel calcineurin inhibitor. And this has led to an inspiration discussion about the paradigm shift in the treatment of lupus nephritis, moving from traditional induction maintenance regimen to the early use of combination therapies. At the American College of Rheumatology 2024 Congress, Annual Meeting Congress, the ACR released a new summary for the screening, treatment, and management of lupus nephritis. And this consists of 28 graded recommendations. 7 are strong, 21 are conditional, and 13 are upgraded consensus good practice statements. The guiding principles of these lupus nephritis guidelines are to preserve the kidney function and minimize kidney morbidity and mortality from chronic kidney disease and treatment, and to ensure collaboration care with the nephrologist, and to utilize shared decision-making, including patients' values and preferences. It also aims to reduce healthcare disparities and consider pediatric and geriatric population. I would like to explain a couple of points here, and that is that when you see these recommendations, they will either be strong or conditional, and the strength of the recommendation depends upon the quality of the evidence, uncertainty about the balance of benefits and harms, and the uncertainty and differences in patient values. So for a strong recommendation for population, most patients in this situation would want to pursue a recommended course of action on only a small proportion will not. For clinicians, most individuals should receive the recommended course of action. For a conditional recommendation for patients, the majority of the individuals in this situation would want to suggest a course of action, but many of them would not due to a number of different reasons. For clinicians, we need to be prepared to help our people making decisions for their clinical situations that are relevant to their preferences and values. Let's review the ACR guidelines, new guidelines. For patients with SLE who do not have lupus nephritis, screening of proteinuria every 6 to 12 months is recommended at the time of clinical flare. For those suspected with lupus nephritis, the ACR recommends performing a kidney biopsy promptly and treating promptly with glucocorticoids while awaiting for the biopsy results and the histopathological results. Patients with SLE who have proteinuria greater than 0.5 grams, they should have a kidney biopsy or when they have an impaired kidney function. In patients with non-lupus nephritis, a kidney biopsy is recommended when you suspect a flare after initial assessment or lack of response or worsening at 6 months of therapy. All patients should receive hydroxychloroquine and RAS inhibitors, and the ACR also recommends to adjust lupus medicine dosages in patients with decreased GFR. I mentioned the institution of glucocorticoid therapy, and here is the recommendation of the new guidelines: glucocorticoid therapy in patients with lupus nephritis for classes 3, 4, and 5. A pulse IV glucocorticoid followed by oral prednisolone less than 0.5 milligram per kilogram with a max of 40 milligrams per day with taper to a target dose of less than 5 milligrams per day by 6 months. This is in concordance with the thinking of the rheumatology community at large, because we know the worsening functions, organ functions, and the risk of infection with the usages of high-dose glucocorticoids in our patients. And a recent meta-analysis also supported the use of pulse glucocorticoids followed by oral dose 40 milligrams or less, and that showed maximizing functions and with minimizing toxicities. And importantly, the patient participation strongly emphasizes the preference for minimizing glucocorticoids during the process of developing these guidelines. Of course, the individualized tapering regimen in clinical practice is going to happen based on both renal and extrarenal disease activities. This is an overview for the lupus nephritis treatment for the classes 3, 4, with and without 5, and for pure class 5. And I'm going to focus on first the treatment for classes 3, 4 with or without class 5. The new guidelines recommend the use of triple therapy, and that includes the glucocorticoids with the addition of 2 immunosuppressive therapies, including mycophenolate mofetil and either the belimumab or the calcineurin inhibitors. The ACR recommends mycophenolate over cyclophosphamide due to reasons of safety. The mycophenolate can be combined with belimumab for significant extrarenal manifestations, and the calcineurin inhibitors can be combined with mycophenolate in patients with heavy proteinuria. The preferred cyclophosphamide regimen, when it has to be used, is the Lupus nephritis trial dose, which is the lower dose for greater safety, and it can be combined with belimumab, although there is very little data to support, and this can be used an alternate regimen of the initial taper therapy. However, the ACR does not recommend the use of calcineurin inhibitors with cyclophosphamide because there are no randomized controlled trials in this area. Why do we prefer triple therapy over dual therapy and with escalation for those who do not respond? So here is there are 2 points to answer this question. One is the best randomized controlled trials up to till to date showed that the improved outcome with initial triple versus initial dual therapy, and that strongly guided panel discussion along with patient panel input and clinician experience. And the other reason is shown in this graph where you can see that the nephron loss precedes the patient's lifetime situation, even in those patients who do not have SLE, and every episode of SLE or every period of time with active lupus nephritis can changes this course rapidly and for the worst, and eventually there is loss of nephrons, which we cannot afford to wait for and implement most efficacious disease. Rapid control is recommended to reduce the inflammation using most effective regimens for the treatment of lupus nephritis so that the kidney function can be maintained. You can see that, you can ask that what is the evidence behind this triple therapy. There are two landmark trials. One is the Bliss-Allen trial, and that showed the benefit with the use of belimumab. And here you can see the primary endpoint with primary efficacy renal response at week 104, 43% of patients who received belimumab, they have shown a benefit as compared to the placebo group, where it was only 32% improvement. The other landmark trial was the Aurora 1 for the use of voclosporin. Here the patients have shown improvement or benefit with the addition of voclosporin to the mycophenolate and glucocorticoid therapy. The primary endpoint was complete renal remission at week 52. Patients who received voclosporin showed up to 41% of patients showed benefit in the voclosporin arm as compared to the placebo. Now I would like to move on the treatment for class 5 lupus nephritis. Although the data supporting this recommendation is very limited, but still the ACR recommends the use of triple therapy, and that includes glucocorticoid, mycophenolate, and with CNI. The CNI is used because of its stabilizing effect on the podocyte cytoskeleton. What should be the duration of triple therapy? The ACR recommends that the duration of triple therapy should be at least 3 to 5 years, and this is required because the rapid control of the disease activity, to gain rapid control of the activities and continued therapy until sustained and inactive disease is achieved. Because repeat biopsy studies have shown immunological activity persisting for several years. And withdrawal of immunosuppressive therapy before 3 to 5 years will actually would lead to flare of the disease, and that is required to remain and can predispose the patient to lupus nephritis. For non-response and refractory lupus nephritis, there is very little data that can guide us, but the ACR conditionally recommends either change to triple therapy or escalate to triple therapy in case if we were using double therapy initially. For refractory disease, the new guidelines recommend to consider adherence and other diagnoses like antiphospholipid-induced nephropathy and advanced chronicity. If a true refractory disease is present, the ACR recommends to escalate therapy to a more intensive regimen, including anti-CD20 therapy or combination of 3 immunosuppressants, or refer patient for an investigational treatment. The new guidelines also, the ACR new guidelines also emphasizes the use of adjuvant therapies for these patients, including prevention of comorbidities such as cardiovascular disease, changes in the bone health, and the risk of infection. The ACR strongly recommends monitoring proteinuria at least every 3 months in patients with lupus nephritis when they have not achieved complete renal response, and every 3 to 6 months when they have achieved the complete response. In patients with lupus nephritis and end-stage renal disease, the ACR strongly recommends transplant over dialysis and conditionally recommend proceed to transplant without requiring complete serological clinical remission, provided no other organ system involvement. In patients with lupus nephritis at risk for end-stage renal disease, the ACR conditionally recommends preemptive transplant, and in patients with lupus nephritis on dialysis and kidney transplant, the ACR strongly recommends the regular follow-up with rheumatologist and nephrologist. Now, let's switch gear and move on applying to the ACR guidelines to class 3, 4, and plus 5 lupus nephritis. We will take a case and then we will move forward. This is a case of 29 years old woman with a 3-year history of SLE who presented with inflammatory arthritis, alopecia, positive anti-double stranded DNA, and he presents to you in clinic with worsening joint pains, stiffness, and fatigue. The medications include hydroxychloroquine 200 milligrams per day and low dose of steroid. On examination, she is hypertensive, normal heart rate and lung, and have inflammatory arthritis of the various joints. Laboratory parameters are notable for various cytopenias, elevated ESR, reduced GFR, anti-double stranded DNA is elevated, C3 is low, and the urine DR showed 3 to 10 RBCs. Spot UPCR is 1 gram. What is the most appropriate next step in the evaluation and management of this patient? Here I presented a case of a patient with SLE who comes to your clinic with signs and symptoms and laboratory parameters that are concerning about the new onset of lupus nephritis. So the first step is to arrange a prompt kidney biopsy for the diagnosis and classification, because we know that lupus nephritis has multiple mimickers. The kidney biopsy is required to ensure a right diagnosis before we commit our patient to years-long immunosuppressive therapy. And at the same time, we will actually treat these patients promptly with glucocorticoids so that the inflammation in the kidneys, which is happening in the kidneys, can be taken care and the kidney function can be preserved. And here you can see the relevant key statements of the ACR recommendations for screening kidney biopsy and good practice statements. And we have already gone through these conditional recommendations and good practice statements. So the kidney biopsy shows a class 5 lupus nephritis, and you can see in the image that there is hypercellularity on light microscopy. A crescent is seen on the second slide. There is an IgG granular deposition in the glomerular capillary wall on immunofluorescence, and there is subendothelial deposition is seen on the electron microscopy. So after discussing with her the diagnosis of new class 4 lupus nephritis, you begin to discuss the various therapeutic options. Your patient tells you that she is worried about her kidney disease and is interested in conceiving in future. She is frustrated with her ongoing inflammatory arthritis, which is impacting her ability to work. She says that the intravenous infusion would be difficult for her due to her work-related schedules. So what do you recommend as a therapeutic management plan for your patient? Here is the summary slide from the new guidelines, and we are on the left side of this. Our patient have a class 4 lupus nephritis. We are going to start her on hydroxychloroquine and RAS inhibitors, and we are going to recommend her glucocorticoids along with mycophenolate and plus belimumab, which is a triple therapy option. And why we are recommending this in this patient? Because our patient have active inflammatory arthritis, which are the extrarenal manifestations of the SLE, and belimumab have demonstrated efficacy in the treatment of extrarenal manifestations as well. And this is how we make a shared decisions, and the shared decision depends not only on the patient preferences, but also on the clinical clues in the real case. So you may ask that what is the evidence behind these recommendations? As I mentioned earlier, this is a pivotal Bliss-Allen trial for lupus nephritis. 448 patients were recruited with active class 3, 4, or 5 lupus nephritis. The UPCR was more than 1 gram and the eGFR were more than 30 ml per minute at screening. All these patients received a high-dose glucocorticoids with 0.5 to 1 milligram per day and less than 60 milligrams, and then taper to less than 10 milligrams by week 24. These patients were given either cyclophosphamide or mycophenolate 2 months prior to randomization for belimumab or to the placebo arm, and then the primary efficacy endpoint was evaluated at week 104. Here are the top-line results of the Bliss-Allen belimumab trial, and the light blue is the belimumab, and you can see that the 43% of patients achieved primary efficacy endpoint with proteinuria threshold of less than or equal to 0.7 gram. On the right side of this slide, you can see the complete renal response in 30% of patients as compared to the 20 in the placebo arm, with a proteinuria threshold of less than 0.5 or 0.5 gram. These are the data from the subgroup analysis of the clinical trials, and based on the baseline protein levels greater than 3 and less than 3. And you can see over here the patients who were receiving belimumab, they have shown more benefit. The patients who actually recruited with levels of proteinuria less than 3, they showed the high probability of benefit in the belimumab arm as compared to the placebo. Let's take a second case. This is a case of 31 years old woman with 2-year history of SLE, manifested as inflammatory arthritis, alopecia, positive anti-double stranded DNA. She presents to the clinic with nocturia and frothy urine. The medicine includes hydroxychloroquine 200 milligrams and low-dose prednisolone. The exam showed that she is hypertensive, normal heart and lungs, and there is +1 bilateral pedal edema. The lab showed 3.7 of WBCs, hemoglobin a bit low, ESR is raised, and anti-double stranded DNA is positive, C3 is low, and the urine showed 3 to 10 RBCs, and spot urinary creatinine ratio is 4 gram. The kidney biopsy showed class 4 plus 3 lupus nephritis. She tells you that she has very worried about the kidney and interested in future pregnancy. She says that the intravenous infusion would not be an option for her due to his traveling schedule. What would you recommend as a therapeutic management plan for this patient? Now I'm moving on to, I will go back to our recommendation slide, and you can see here that we are going back to our summary slide here, and we are going to recommend immunosuppressive therapy, but in this case we are going to recommend triple therapy with CNI. And why is that? One of the deriving feature in this case is the UPCR of 4 gram, and this is crucial. We know that from multiple mines of data, earlier we can reduce proteinuria, better would be the long-term kidney outcome, and all these features are thinking about the CNI. What is the evidence behind this recommendation? The Aurora-1 trial with voclosporin for lupus nephritis. This trial recommended 357 participants with active class 3, 4, and R5 lupus nephritis. UPCR was 1.5 gram, or more than 2 gram, and the eGFR was more than 45 ml per minute. These patients received lower dosages of glucocorticoids like 500 milligrams of prednisolone times 2, followed by prednisolone dose of 20 to 25 milligrams with a taper to 2.5 milligrams by a week. Here you can see the study design. The participants were randomized to voclosporin or placebo on the background of mycophenolate mofetil. The mycophenolate mofetil dose was 2 gram and is different from the Bliss-Allen trial, and the complete renal response, the primary endpoint was week 54. Here are the top-line results of Aurora-1 voclosporin lupus nephritis trial. The primary endpoint at week 55, you can see the superiority of the voclosporin over controls. I would like to show you the time to UPCR with voclosporin in blue and the controls in red. There is a rapid differentiation early on where you can see the reduction in the proteinuria in the voclosporin arm. And this is because of the non-immunological effects of the CNI on the cytoskeleton of the podocyte, and also because of decreased apoptosis. Now we'll move on to applying the ACR guidelines to the treatment of class 5 lupus nephritis. Let's take another case. This is a case of 40 years old woman who is diagnosed to have SLE 7 years ago, manifested as arthritis, leukopenia, rash, and positive ANA. No medical history of hypertension or coronary artery disease, no evidence of kidney involvement to date. She presents to you for biannual appointment of and complaining of periorbital puffiness and swollen ankles. The medication include hydroxychloroquine and the low-dose prednisolone. The exam showed normal blood pressure, normal heart rate, plus 2 pedal edema. There is mild leukopenia, but the ESR is 56. Anti-double standard DNA is negative. C3 and C4 are normal. The bland active sediment in urine plus 3 proteinuria, and the UPCR is 3.5 gram. Here I would like to submit the ACR new guidelines for lupus nephritis, and that recommends performing a kidney biopsy in patients who have proteinuria less than 0.5 gram and are impaired kidney function. In addition, I would like to remind you about the good practice statement that says the prompt use of glucocorticoids at the time of diagnosis so that we can suppress the inflammation and can preserve kidney function. Here is the kidney biopsy results, and you can see the thickening of the glomerular membrane on light microscopy. On silver stain, there are holes and spikes of the glomerular capillary wall, and that are consistent with membranous lupus nephritis. There are deposits of immune complex on immunofluorescence, and there is subepithelial deposits on electron microscopy. After discussing with her the diagnosis of class 5 lupus nephritis, you describe the first-line therapeutic option. What do you recommend as a therapeutic management plan for this patient? Let's again focus on the guidelines recommendations. For class 5 lupus nephritis, we have looked at 2 cutoffs of proteinuria. One of them is greater than 3 gram, and the other is less or equal to 3 gram. So in patients with active, newly diagnosed pure class 5 lupus nephritis, the ACR recommends patients with low levels of proteinuria a triple therapy of glucocorticoids, mycophenolate mofetil, and CNI. The ACR also recommends treatment of patients with low levels of proteinuria with glucocorticoids and immunosuppressant because these patients may progress to high grade of proteinuria over time. Here you can see the goal of treatment for all classes of lupus nephritis is to achieve a complete renal response. And complete renal response within 6 to 12 months and reduction in proteinuria less than 0.5 gram is another goal with the stabilization or improvement in the kidney function. As the guideline said, the duration of therapy would remain 3 to 5 years after achievement of complete renal response. What is the evidence behind these guidelines? Let's walk through this decision tree. The diagnosis of pure class 5 lupus nephritis is made on kidney biopsy, and the decision tree splits whether the proteinuria is a gram or less than a gram. For our patient, proteinuria was 3.5 gram. Therefore, we go to the right side of the decision tree where the ACR guidelines recommends the use of hydroxychloroquine, RAS inhibitors, and the triple glucocorticoid therapy with mycophenolate mofetil and CNI. And these results are are based on the post-hoc analysis from the clinical trials that supports the use of voclosporin with mycophenolate mofetil and low-dose corticosteroids. They can reduce the proteinuria early on in class 5 lupus nephritis. A formal evaluation should be done at 6 to 12 months. And if the patient achieves partial or complete renal response, we will go to the left side of this decision tree. We will taper off and stop glucocorticoids if we do not achieve complete remission. We need to assess adherence therapy if the complete renal response is not achieved, and we can possibly switch to an alternate therapy or can use a non-conventional therapy like anti-CD20. The next follow-up should be planned at the 6 to 12 months. And at the next follow-up, in case of partial renal response, we will continue with treatment until we achieve complete renal response. After complete renal response is achieved, we will reduce the glucocorticoids to 5 milligrams by 6 months and continue maintenance therapy for 3 to 5 years. On the other hand, if we are not able to achieve a complete response, we need to assess adherence, consider repeat biopsy to rule out other diagnoses and advanced chronicity. We may consider anti-CD20 therapy or combination with mycophenolate, belimumab, and CNI, or this patient can be referred to an investigational treatment. Let's review the evidence behind these recommendations. I will walk you now through some of the evidence that support these guidelines. There are data from the integrated analysis of phase 2 trials of Aurora LV and Aurora for voclosporin. The area that is squared in shows that the patients with pure class 5 lupus nephritis, the odd ratio for achieving a complete renal response is 1.5. Of course, you note that the confidence interval crosses the white line, and this is because of the fact that the number of patients in this integrated analysis were low. Belimumab efficacy evidence. These are the data from Bliss lupus trial looking at patients with pure class 5. These patients have odd ratio of less than 1 for complete renal response when treated with belimumab. Therefore, this is not a good option for our patient with class 5 lupus nephritis. These are the data from pooled analysis of the voclosporin trials that show in patients with class 5 lupus nephritis, patient treated with voclosporin had a high probability of achieving 50% reduction in the UPCR at 1 year compared to the control arm, and at the time of the UPCR to less than 0.5 gram was 176 days in the treatment arm compared to the 295 days in the placebo arm. These are the EGFR data that shows while there was a slight decline in the mean corrected EGFR for patients treated with voclosporin, the mean EGFR remained in the normal range with a slight change from the baseline of -1 at 1 year mark. Back to the case. This patient was started on a regimen of pulse glucocorticoids followed by prednisolone 20 milligrams per day, mycophenolate, voclosporin, and losartan. She continued with hydroxychloroquine. After 6 months, she achieved a partial renal response with UPCR of 1.5, EGFR of 80, and double stranded DNA negative. Normal complement, prednisolone is down to 5 milligrams, losartan is continued, and the mycophenolate level is 4. While the level is therapeutic, you ask about medication adherence. And she admits that she has difficulty with the number of pills and asks about alternate options. She has not experienced any toxicity from the mycophenolate. What do you recommend as a therapeutic management plan for at this stage? Patients with membranous lupus nephritis takes longer to achieve a complete renal response, and we would not expect complete renal response at 6 months into this treatment. So please do not switch to an alternate regimen. Consider tapering glucocorticoid to 0, continue with mycophenolate mofetil with CNI and losartan, and consider adding SGLT2 inhibitors. These agents have not been evaluated in the ACR guidelines, but recent observational studies supports their use in patients with persistent proteinuria. With that, I would like to end and thank you very much for your attention and time. I will be happy to take questions at the end.